So hi, I'm Aparna. I am a psychiatrist and also one of the co-founders of Marvin. And so today, during this training, we're going to take a deep dive into essentially the physician lifestyle, kind of what it takes like during residency and common mental health issues. And then we'll take some questions after the presentation as well. Is
for resident physicians and physicians. Number three, I wanted to highlight is stepping away from the computer, but also, as a physician, a resident, there's a complexity, right, as far as interactions with other care team members. And that can be a real point of stress, whether that's how you deal with your more senior resident or your attending physician, or how you interact with the nurses or the consults, whoever that is, that can always thing due to maybe communication, and different flows of information from one team member to the other. But it's a very high level source of stress that's common. Number four, kind of now stepping away closer to the job in patient care. Obviously, generally care is, involves, action and their reactions that occur. So it's a
yeah, looks like Dan is definitely having some connection issues.
It's breaking up a lot.
Yeah, I don't know, Dan, if Dan, we can't.
Can you guys
really,
use my reception breaking up?
Yeah, we can barely hear you. It's like very choppy. So I don't know if you want. I don't know if you can like move or something, or otherwise we could maybe try to come back.
If you want.
Yeah.
Okay.
Don't want to miss it, but
yeah. Maybe Dan, so I could just maybe take over on the like with the training, and then maybe if you're able to join later at a different spot or something, we could come back to you if that works. Yeah. Okay. Okay, so I guess maybe we can go to the next slide and we'll come back to Dan if he's able later on.
okay.
Okay, so yeah, so I guess I can kind of also speak to this. So in terms of medical training tends to be like very, or in general, very long, but it can vary somewhat in terms of length of training. Dan was talking about his experience recently as a resident, and then also now as an attending. And you know, I'm a couple of years like older than Dan, but also relatively close to residency and medical education. So yeah, so generally like very long training period, undergraduate education, typical like 4 years, and you can major in a number of different things, but need to complete a pretty rigorous pre-medical curriculum, and then also score very well on the MCAT to even be admitted to medical school. Then start medical school 4 years, during which we have, you know, throughout this presentation, we have cited academic papers, and so you'll see the citations here, so I won't like spell out all of them, but if you want to know which study something is from, we're happy to get back to you later on that too. But anyway, so during the 4 years of medical school, often a lot of students report mistreatment from supervisors. This one study mentioned 80%. So there's the preclinical years. The first 2 years are preclinical, which is, you know, a lot of kind of anatomy and physiology, a lot of just a huge volume of material to learn, and kind of studying all the time with very few breaks from that. And then at the end of those 2 years, have to pass a board exam called the USMLE Step 1, which is very rigorous. I would say probably the most rigorous exam during the medical school process. I can't speak to specialty boards later on, but it's like very time consuming to study. Prep for exam itself is like 8 to 9 hours during the day continuously. And so very big stressor. And then the last 2 years are clinical rotations. So rotating through different specialties like OBGYN, internal medicine, psychiatry, surgery, for example. And during that part is predominantly, I think, when medical students report mistreatment from supervisors. They're kind of the lowest, they're lowest on the totem pole in the clinical setting, and so are often subject to mistreatment. And then after medical school, or during medical school, during their 4th year, the medical students apply to different residencies. Some are more competitive than others as a specialty. And then even some of the less competitive specialties, it's also very difficult. It's very competitive to get into a prestigious program, and so like a prestigious hospital. And so there's a lot of kind of like competitive pressure there within medical school, then and even getting into the residency and of your choice. And during residency, residencies are usually 3 to 5 years, and some can be a bit longer if there's like a research, if you choose to do a research component. And during that, you're working very long hours with, and often for like pretty low pay, a lot of student loans, and you know, not getting very good sleep. We'll talk more about that going forward, but essentially, yeah, 3 to 5 years of that. And according to a couple of studies we have cited here, close to at least like 25% of residents actually report depression by the end of their first year. And the first year is often called the intern year, but yeah, huge amount there. And then sometimes, yeah, people will also complete additional subspecialty fellowships after the residency process. And then after all of this, you will often have to sit for specialty boards in both the specialty of the residency, and then perhaps like a subspecialty board as well in what you did your fellowship in. You can go to the next slide. And so I'll just, you know, go through these briefly, but mentioned some of them earlier in this earlier slide, but there are a ton of physician-specific stressors that you can look out for. Some of them are kind of common to, many different jobs or different types of healthcare positions, but I'll talk specifically about physicians here. So, there's a number listed here. I won't go through all of them, but I think one of the huge ones is lack of sleep, or actually very irregular sleep, in terms of residents go through different sort of training rotations, and so often are switching from hospital to hospital, or from inpatient to outpatient, or between specialties every couple of months, and or sometimes like even more often than that. And so are in addition to often working very long hours and not getting much sleep, are asked to kind of flip between nights and days. They may work 2 nights a week and then have to work 3 days. And so really having very irregular hours in terms of sleep, being able to catch up on sleep, and that's repeated over 3 to 5 years. And so it's kind of this chronic sleep deprivation, and also just kind of ruining their natural sort of circadian rhythm and over a very long period of time. And additionally, other kind of like specific to physician stressors could be to other healthcare workers as well, but exposure to patient death, and then also and harm, and then also this one of the kind of larger burdens that's that people have reported, especially in the last 10 or 20 years, is this constant threat of malpractice litigation. Different specialties have kind of different rates of malpractice insurance. Like some specialties like neurosurgery have, almost like most neurosurgeons will probably be sued at least once, often several times in their career, many of which are not, negligence. Like it's a high risk specialty, right? And so there's kind of like that that general atmosphere looming over physicians, both in training and as attending physicians. And Dan mentioned the EHR, the EMR as well, which I think, over the last 15, 20 years, has started, has been actually like very beneficial to healthcare and to patients in some ways, and physicians, but also has become extremely burdensome. So that's a lot of physicians, really feel like that's taking time away from the time that they get to spend with patients. And so they're, the patient encounters are becoming maybe like 20% or 30% of their day, and they're spending like 30% of their day on the EHR, sometimes more than that, depending on specialty. And so that's a source of burnout, which we'll talk about more. And yeah, I think like there's a number of other things here, like, but last time we did this presentation one time earlier and we went very long, so I will speed it along. We could talk about some of these later if we want to come back to them.
Okay.
So we could go to common characteristics, or the next slide, yeah. So I'll just talk a little bit about some common characteristics of doctors, physicians. Obviously, people will vary, but these are just like some common characteristics that have been found in some of the literature. Tend to have high intelligence, conscientious people. But actually, one of the traits that has been found very common is an obsessional sort of personality. This can be, positive in terms of perfectionism and wanting to do a great job, and making sure that they're providing the right type of care and right type of intervention, but then also can lead to being perfectionistic in a lot of kind of like dysfunctional ways, like overcommitment to work, inability to relax, inability to kind of take themselves away, like mentally, from kind of this hospital environment all the time. And actually, yeah, and another, and with all of this, a large percentage of physicians actually don't end up seeking healthcare for themselves, which puts them, even more in a weak position to be able to deal with a lot of the stressors I mentioned. And sometimes that's because they feel like, well, they kind of already know if it was something serious, they have the training that they would have kind of diagnosed themselves. And other times it's simply because, they're working so many hours and don't really have much flexibility, at least until their complete residency, and sometimes even after that. And so, yeah, just kind of put off self-care and in lieu of caring for their patients.
Sorry.
We can go to the next slide. I don't know if Dan is back or.
Yes, I'm on the phone.
Okay.
You guys can hear me now.
Yeah.
Yeah.
You're better. So yeah, you could go ahead, Dan.
Okay. Awesome. Are we on the slide with the years of training?
Yeah,
for,
internal medicine residency years in training.
Okay,
yeah.
great.
Yeah.
So as far as during your encounters with the residents on Marvin, like the framework it is, we have basically 3 years for internal medicine residency. The first year is usually the hardest year. It's called the quote unquote intern year. You're basically in the field. You're the first person that gets paged for any patient concern. And so you're really adjusting to a new environment. It's a new job. Medical school in a lot of ways doesn't train you for this. So you're learning, the logistics of being a doctor, but then also the technicalities and the knowledge of being a doctor. And then also then dealing with the long hours and, again, navigating the relationships with your more senior residents and then the attending physicians. The second year of residency generally is called that you're no longer on the ground floor getting all the direct pages, but you're responsible for managing double the number of patients, but at a much higher level. And so really you're trying to transition into a leader. You're trying to provide guide rails for your interns, but not to micromanage them. This can be particularly challenging for residents who are, very, very detail oriented and need to micromanage every detail because now they have doubled the patient census. So that's often a point of stress during junior year. And then as you make our way to senior year, you basically fill the same role as the second year, except now you just have an additional year of experience. You also use that time to focus more on teaching and kind of preparing for the next steps in your career, which is whether it may be fellowship, so more training in a specialty, in a subspecialty like cardiology or pulmonology for the lungs, or you may go into practice as a generalist, for example, like myself. And so third year is often more relaxing, but does pose a different set of stressors. I think more so just navigating career pathways. That's often on top of the mind for a lot of senior residents. And that's all I had to share for this. Any questions here? Excellent. Okay.
Cool. So I'll talk a little bit more about navigating residency relationships, just more generally. And yeah, so there are a number of different kind of relationships that a resident is navigating. One might be their relationship with their the attending physician, or who's essentially like their boss. It's the faculty faculty physician that's supervising them. And so that's one thing that some attendings are very understanding and really care about teaching, but there might be others that are more interested in research or kind of like administrative, and they're kind of just like asked by the institution to be an attending and teach a few shifts, and sometimes they're not so happy to be there, or aren't that invested in kind of the learning of the residents, and so that can be difficult sometimes. And just historically, medicine has like a pretty hierarchical system, and so sometimes it feels like a similar hierarchy to I've heard it described as like similar to like the military or something like that. I mean, it's probably not quite as rigid, but it's definitely very hierarchical, and still is even today, and a little less so than before. But so yeah, the resident relationship with the attending physician, also with other residents at kind of different levels, senior residents. So if they're a year or two above the resident, then they also somewhat serve as a supervisor over the junior residents. There are chief residents who each resident may have a relationship with as well, and chief residents can either be often either final year residents, or some of them can be they've completed residency, but they kind of stay on for an extra year to do doing mostly like administrative tasks, and it's often considered like an honor to be a chief resident. So a lot of people stay on for that, and yeah, so in addition to relationships with other residents and attending physicians, there's also a relationship often with nurses or other like allied health professionals, and sometimes that's that's difficult as well, because a lot of nurses, they may have been working at that particular location for 20 or 30 years and actually have a lot more understanding of some parts of the environment than the residents might, and so sometimes there's friction between kind of like these new, very young, inexperienced kind of like first year residents or second year residents coming in and then giving orders to the nurses in terms of and there's sometimes like friction there in terms of communication style and that kind of thing, but having a great relationship with nurses can also really be very helpful to residents, and so trying to maintain a good relationship is always like ideal, but that's yeah, another thing they're juggling kind of in addition to these other relationships I mentioned. And yeah, last thing, I mentioned this earlier actually, but there's a lot of hierarchy within medicine. Most academic medicine institutions, so like teaching hospitals where people where one would do residency, tend to be both hierarchical, and then also a lot of the people that stay on in academic medicine tend to have a bit of an ego, or and feel like their status in academia is kind of like reflects who they are, and so there's difficulties there as well. We can go to the next one. And in addition to these relationships within the hospital, which I just talked about, there are relationships to maintain outside of the hospital as well. So most of these residents are, somewhere between 25, 26, and maybe 35. There are a few that are older. There might be a few that are a little bit younger than that, but generally, so are going. So they may, in that age group, they may be either like recently married or looking to get married, or they may have like a recent, may have actually had a child, or may have young children. So in addition to, all of these hours that they're working, all these relationships they have at the hospital, they're also trying to maintain relationships outside of the hospital, like personal relationships. And with this constant workload, many residents will say they feel like left behind in terms of life milestones, because they've been kind of in this like education system, or this process of education for maybe like 12 years at 12 or more, 15 years, or at the end of it, and so often feel like they may not have reached some of the same life milestones as their peers. And yeah, and also distance from family and friends is an issue that residents and fellows deal with. Simply one of the reasons is that there is a match system, that residency match system that's used at the end of medical school. You apply to a bunch of different residencies and you rank which ones are your preferred hospitals or programs, but there's a final match kind of algorithm that kind of the rankings go through, and then you're matched to a particular hospital, and then you're kind of bound to go there. And sometimes people don't get the hospital or program that they wanted, or sometimes they don't even get one of their top 5 choices, and so they might end up in across the country from where they wanted to end up, and then have to kind of navigate living far away from friends and family, missing holidays and milestones with their family because they have such a busy schedule and a few days off. And so that's another stressor. You can go to the next slide. This slide is just about residency stressors. Some of the things I kind of already mentioned, demanding schedules, stressful environment, conflict with coworkers, could be nurses, could be sometimes demanding patients, just this additional student debt, and sometimes feeling trapped because they've already invested so many years in training and education, and have taken out loans, and some residents may actually no longer even be interested in medicine, or have gotten really burned out from it, don't really want to continue, but have so much debt and have not really received kind of training outside, haven't held kind of a job outside of of kind of education and outside of medicine, and so feel like they really can't really get out. They have to keep going. Yeah, so we can keep going. I'll talk, I could talk a little bit more about this. I'm trying to go a little faster today. So burnout is physician burnout is a public health crisis. From this, we're citing an excerpt here from A Crisis in Healthcare, which it talks about physician burnout. And I think physician burnout has maybe come more to the forefront in the last year due to kind of COVID and more spotlight on physicians and healthcare workers. But generally, the general definition of burnout, it's kind of a universal problem. It can affect many different occupations, but physicians have a much higher risk. It's not an official psychiatric disorder. It's more of, I guess, like a syndrome caused by chronic distress associated with work, very prevalent among physicians, and has been rising with recent studies showing over 50% of physicians have said that they're either currently burned out or they have been burnt out at some point. And physicians at the highest risk for burnout are usually during their residency fellowship training period, or in the middle of kind of mid-career. And the 3 dimensions of burnout, so emotional exhaustion is one, feeling kind of depleted of mental energy, feeling like they're just you are overextended, drained. Yeah, just overall emotionally exhausted. And the second dimension, depersonalization. So this is feeling detached feelings towards the patient, feeling kind of cynical, jaded, having a hostile attitude towards patients, and so feels maybe almost like us against them, or a feeling like that, where patients are started to be viewed more as kind of objects, or the enemy, or something along those lines. And the third dimension, reduced personal accomplishment, and so this is kind of feeling negatively about oneself, feeling incompetent, even though they're very well trained and are likely excellent, doing excellent work, but feeling that they are not. And 45% of surveyed residents in this study, Conlucci et al., that we mentioned here, reported symptoms of burnout. Yeah, and we can keep going. So some more signs and symptoms of burnout. There can be some physical manifestations as well, getting sick kind of frequently, colds, headaches, fatigue, just in general, more moodiness, or feeling more irritable, having trouble with sleep, feeling less empathetic, feeling detached from patients, like I said, and sometimes engaging in unprofessional behavior, or perhaps yelling at patients, or at nurses or other colleagues, and yeah, you can keep going. Those are some of the big ones. There are a lot of factors that contribute to burnout. Mentioned a few before in terms of, I'll just kind of briefly touch on some. One of the ones I mentioned was the documentation burden. So the EHR, very intrusive, often expect insurance companies or kind of dictate what the amount of information or the type of information that needs to be entered in the EMR, and the things that are requested by the insurance companies, seem to be growing longer and longer, and hence physicians are spending much of their time documenting rather than on patient care. And then, yeah, just the rapidly evolving nature of medicine. So sometimes this is like evolution of regulations and increased clinical volume, different requirements by different payers or medical boards or employers. Certain specialties are higher risk for burnout. In this particular study that we have here, internal medicine, neurology, and emergency medicine were highest risk. And yeah, there's, I think like one of the interesting things too, and a number of studies show this, is that early, especially like female physicians tend to have a much higher rate of burnout than male physicians. And one of the hypotheses kind of behind this is often female physicians, in addition to all of the responsibilities they have at work, are often having to bear the brunt of of caring for children, or if they have like sick family members, or generally even in sort of an egalitarian relationship, are still like expected to do much of the work at home, in addition to this maybe 80+ hours as a resident. And yeah, I think a number of other things here too, but we can keep going. Those are just some ones I want to highlight. Consequences of physician burnout. So in addition to just the physician's health consequences themselves, there are a number of others. So patient care, physicians that are burnt out tend to have more, or have an increased rate of medical errors, perhaps, and in some instances, increased risk of malpractice, leads to often less patient satisfaction, and patient outcomes are affected in some cases. Also big healthcare costs in terms of physicians that are burnt out will often leave their job at a certain institution, maybe after only 6 months or a year, and whereas in the past perhaps they stayed for much longer, and this leads to there's a huge financial burden to recruit new physicians, and so it's a big cost to the system as well. And patient care can also be affected there, just with kind of repeated handoffs to new physicians, and there can be kind of some medical care that's lost in this transition. And physician health is also greatly affected. Physicians feel tired, exhausted, can lead to actual clinical depression as well. We can keep going. So there are a lot of studies that we've cited here. Clearly, I'm very behind on timing here, I think, so maybe want to move a little bit faster, but yeah, physician burnout in general associated with increased risk of patient safety issues, poor quality of care, less patient satisfaction. So that's from that side. And then there's also risk to the physician themselves. And as I said, female physicians and early career physicians tend to have high rates of burnout. The next So the Maslow burnout inventory is a type of, I think probably a lot of people are familiar. It's used to measure burnout, has like the 3 dimensions. We mentioned emotional exhaustion, depersonalization, and personal accomplishment or ineffectiveness of accomplishment. And that's commonly used for medical professionals. We can keep going. There are several other kind of scales or that are also used. Here's a few additional ones. Copenhagen Burnout Inventory, Wellbeing Index. Can talk about more, but in the interest of time, we'll keep going. And then moral injury is another thing that that's kind of unique to healthcare. And moral injury is another like risk to physicians, and one of the things that they deal with on a frequent basis. And it describes the challenge of simultaneously knowing what care patients need, but then being unable to provide it because of constraints like beyond their control. This could be like insurance benefits, or often not enough, there's like short staffing, so hence they're not able to provide the level of care they need, or they're being dictated by the healthcare system to do to provide a certain kind of care when they know that something else would be better for the patient. And so that tends to be particularly difficult on physicians and contributes to burnout. Can keep going. Differentiating, to differentiate between burnout and MDD with depression. I think there's most of the people that are watching this Marvin presentation are clinicians, so they probably have some understanding already. But essentially, depression, is not equivalent to burnout. But MDD or depression is often framed as burnout because burnout tends to carry less stigma with it. And yeah, but it's important to make the distinction early to understand what type of treatment would be best. You can keep going. So major depression, most of the clinicians, on here are familiar, very familiar with major depression, but in terms of for physicians, an interesting statistic is that physicians, by the time they reach residency, their depression rates are 4 times the national average, and physician suicide rates are and continue to be twice the national average. But a very small percentage, for example, here, only about 15% of depressed medical students sought out psychiatric care. That is for a number of reasons, likely some of the ones I already talked about earlier on, but another thing that tends to keep physicians and medical students and later career residents and later career physicians as well from seeking psychiatric treatment tends to be concern that they may be barred from continuing to see patients, or they may be prevented by the state or national medical boards from practicing if they are to disclose a psychiatric illness. Many licensing boards, many state licensing boards ask specific questions about physicians' past mental health and treatment, and so either the physicians are left with a choice of either lying on this medical board application or disclosing it and fearing that they may not be able to practice, and hence so a lot of times they don't seek out care for that reason. That's getting a bit better in terms of there have been like a number of petitions and initiatives to get these medical boards to either reword the questions or remove questions about mental health on the licensing applications, and that's been successful in some cases, but there's still ways to go on that. Can keep going. Some more, we have some more notable like research here. I think we could probably skip this slide. Just mainly just saying like depressed residents tend to make more medical errors compared to non-depressed residents. Mentioned this a bit earlier, but physician suicide continues to be an issue that's largely overlooked outside of academic medicine, but is becoming coming more into the spotlight. 300 to 400 physicians take their lives every year, and the suicide rate for female physicians, I think, as I mentioned, is much higher than the general population, about 130%. And the suicide rate for male physicians is also higher than the general population, but about 40%. So not as stark of a difference, but still higher. And yeah, we can keep going. So a number of different conditions show up with doctors that have continued, both from they may also have some biological predisposition or other experiences in their lives, but also a lot of this kind of psychiatric or psychological illnesses that we'll talk about can be a direct result of like some of their experiences in actual training or in practicing. So PTSD more prevalent in doctors than the general population. Simply, they're seeing it's a higher likelihood that they're experiencing traumatic events, seeing death or grave illness on a very frequent basis. Physicians most prone to PTSD tend to be emergency medicine physicians, and then followed by residents or trainee physicians, and then physicians involved in malpractice litigation. And so that can be, I mentioned there are some specialties that are have very high malpractice rates, and so those specialties may be more affected. Can keep going. Another issue that's very prevalent with physicians, or I don't want to say very prevalent, but is an issue with physicians is substance abuse. This is associated with higher rates of suicide. It's 5 times higher than the general population, which is a bit shocking. Alcohol is most commonly abused, but also, with physicians, they have greater access to prescription drugs, perhaps controlled substances. And so a lot of abuse there as well, with opioids and benzodiazepines being most commonly abused in that category. So substance abuse, common symptoms of physician or resident with substance abuse. And you think like some of these are, just common to anyone with substance abuse, but often with physicians, just kind of like a common saying will be, their work will be kind of the last thing to go in terms of, there are many physicians with perhaps like substance abuse issues that still, seem to be very functional, are able to practice medicine at a fairly high level until their substance abuse becomes, kind of really severe and problematic. And so at that point, perhaps their performance will be impaired, but often it can go for, many months or even years without being detected. So just, I think here we're just citing that, there's a lot of substance abuse among physicians, but also medical students, and commonly abused commonly abused substances are like prescription drugs. So we also wanted to, I guess, talk a little bit about COVID specifically, and how that's impacted physicians. I think a lot of that has actually, been publicized more in the media, so you might have somewhat of an idea as well. But in general, physicians note a lot of like mental exhaustion, anxiety earlier on in the pandemic, especially when they often didn't have proper protective equipment, anxiety about being infected, anxiety about infecting family members, and just a lot of increased exposure to death, well beyond maybe any other part of their training, and then isolation from having to be away from perhaps their loved ones for fear of infecting them. And then actually something that a lot of people maybe aren't aware of is especially a lot of specialties that have a lot of elective procedures. Kind of due to COVID, all of the elective procedures were kind of canceled and or put on hold for long periods of time, maybe months. And so a lot of physicians also saw a lot of financial, or some specialties saw financial hardship during COVID. So yeah, we'll just talk a little bit about barriers to seeking care. Generally, I think this is kind of broad statement, but a broken healthcare system, physicians, a core contributor to kind of poor mental health with physicians is just the culture of medicine, which I mentioned is like hierarchical, also has tends to have kind of a history of sort of bravado, or and the regulatory climate of the medical system as well. And I mentioned like the licensing questionnaires that kind of are problematic, and that's part of this like regulatory climate of the medical system too, which actually does a disservice to physicians. Can keep going. And I mentioned this a bit earlier, but there's also like the culture. There's a culture of fear with physicians, and also this kind of culture of self-sufficiency. And so both of those things together lead to things like self-prescribing medications, which rather than seeking out care, can keep going. And so there are interventions that there's a number of different levels at which interventions can be taken, and there's organizational interventions. And I think like things there that are commonly cited in the literature is addressing workload and the amount of like EMR, EHR burden, and then accessibility to care. A lot of physicians are very concerned about confidentiality when seeking help. So often, if there is like an in-house psychiatrist or psychologist that's hired by these hospital systems, a lot of physicians will, not go in or like purposefully avoid going into these people simply because they don't want it to be tied back to them, go into perhaps the same EMR, EHR system, or be like used against them in promotions and that kind of thing. The licensing questions issue I mentioned already, and removing questions like that on state medical licenses or national would really do a lot to encourage seeking care. And then there are some targeted programs that could be helpful at an organizational level as well. This is simply something like as easy as having the doctor's lounge back. There used to be doctor's lounges, I think in hospitals. I want to say, I remember maybe when I was a kid, they were around like in the 90s, but I think have increasingly kind of gotten replaced by, instead of Doctor Lounge being someplace for doctors to sort of hang out and debrief about what their issues, clinical issues or things that they're dealing with, have now become turned into like computer lounges where they're spending their time documenting on the EMR. And so a lot of hospitals actually like brought back the doctor's lounge, both as an area for doctors to be able to collaborate and sort of hang out, and also kind of symbolically saying like, we recognize this is an issue and we want you to have this space. Physician health programs are another kind of intervention. There are state-based support programs for physicians. This is like mainly I've seen with substance abuse issues, not perhaps mental health issues in general as well, but largely I've seen for substance abuse. And in some states they offer coaching and preventive services as well, but often just like kind of you'll hear like, oh, this physician got sent here because they were like bad and they were abusing drugs, so they get like sent away to these programs. So generally that also carries with it like some stigma. And so we can talk about this at the next maybe our next Marvin training, but there are some common modalities that could be helpful for physicians or for treating physicians. These include CBT for depression or depression, anxiety, and PTSD, EMDR, perhaps, dialectical behavioral therapy, DBT, MBSR. So these are, common modalities that can be used for a number of different populations, but we can talk about specific applications to physicians and healthcare workers at a future session. And then we have some additional resources that we can send to you if you want. And one of the interesting ones here is so Pamela Weibel, I think Weibel is how you say her last name, but yeah, so she's I think a family medicine physician based in Oregon, and she does a lot of kind of talks and has a business basically that provides like physician retreats, and also she states kind of her life's purpose is to prevent physician suicide, and so she's an interesting person to listen to. She has a lot of things up on YouTube and other places, but yeah. And so I think that's it for our training. We're just at about time, but if anybody has quick questions, we can take them. And yeah.
Yeah, Christy. You're on mute, sorry.
Okay, do we have access to these slides? I took pictures of some of them, but
Yeah,
a lot to take in.
I know, lots of info. So thanks to Barna and to Francis, who's on the call, who will put some of this together. We will send it out. We also have a recording, and we'll send you 3 things afterwards. We'll send you the slides, the recording, and also a quick survey just to get your feedback. And we're super open to feedback and would greatly appreciate it. And the final thing I want to say is we are working to get this sort of certified as a continuing education credit. And we've already applied for that, or we applied for that. It's going to take a little bit of time to process, but I will reach out to you in the future regarding that.
Thank you. Thanks, Aparna.
Mm-hmm.
Thank you.
Thanks everyone for attending.
Cool. So with that, really appreciate everyone joining. It's been great to spend the hour with you, and thanks again for working with the healthcare workers, and thanks to Aparna and Francis for putting this together.
Thank you.
And happy Friday.
Yeah.
Thank you.
Bye.
Bye-bye.
Bye, everybody.
Thank you, everyone.
Yeah. Bye.
Go Marvin, Team Marvin. See ya.